Everybody focuses on this today, but don't forget the functional success that we spoke about in the first lecture today. Okay, here are some nice looking implants. All of them are which tooth? Central incisor. Who says the left? Left? Or the right? Can anyone pick the set? All of them are left central incisors. Those that were right, I flipped it around so that they're all on the left, just to let you know. Of course, this is what we try and strive to achieve, and these are all my cases. And when you go and hear a lecture on aesthetics, they will always show you the best cases, isn't it? But we know the truth is not quite like that, because these are some other cases, all my cases as well. Right? So these are not perfect aesthetic results. Some of them have got complications. Some of them started off with periodontally involved teeth, so there was no papilla to start with. Some of them have had the effects of growth, ongoing facial growth, and we have the incisal edge step. One of them is a facially malpositioned implant, which is this one here, and we have the recession. Right? So the reality is that things are not always as perfect as they would like to be. So I asked the question, what is it really like out in the dental community? What level can we expect to achieve when we deal with single teeth? Now I'm focusing on single teeth in the aesthetic zone. So by and large, the way we measure aesthetic outcomes is to look at symmetry. So we have a tooth that's replaced, then we compare it to the contralateral tooth. For a central incisor, it's the tooth next door. We look at the color of the tooth, the shape of the tooth. We look at the profile of the soft tissue. We look at the level. We look at the papillae. And all we're trying to do is look at symmetry. How close are we to mimicking the natural situation of the neighboring tooth? So the most common indices are the Furhauser 2005, the pink aesthetic score, was Furhauser, and then the white aesthetic score of Belzer, looking at the teeth. Yeah. So there are other aesthetic indices around, and these are fundamentally the ones that we looked at. So in the fifth ITI Consensus Conference 2013, I wrote a systematic review with Professor Danny Bruiser, and the question we asked ourselves is, what was the influence of implant placement timing, immediate, early, late, and any augmentation procedures on aesthetic outcomes in the anterior maxilla? So that was the PICO question that was posed. And although there were a number of aesthetic indices reported, as I said, this was the most common one being used at the time, and even today, it's the one that is the predominant aesthetic index that's used. And the pink aesthetic score looks at 7 factors. It looks at the mid-facial mucosal contour on the mid-facial. It looks at the level of the soft tissue. It looks at the height of the distal papilla compared to the distal papilla of the contralateral tooth. It looks at the mesial papilla. And of course, when it's 2 central incisors, then the mesial papilla is shared between the implant and the contralateral tooth. Look at soft tissue color, look at soft tissue texture, and one thing that we don't look at very often is the alveolar process fullness. So it's the fullness of the alveolar process. How much does this contour mimic the contour of the neighboring tooth? Okay, because that's really important for how light hits the soft tissues and reflects back again, if it's convex. If it's concave or flat, you get very different appearance of the soft tissues. Now each of these is scored a score of between 0, 1, and 2 to give you the score. So you can have a maximum score of 14 for aesthetic outcomes. So I take a look at this case of mine, I score this myself. All right, so you have a look at this score here. So I score myself a mid-facial contour of 1, because it's not perfectly symmetrical with the other 2. The level is good, the papilla is short on the distal, it's short on the mesial, the color is good, soft tissue texture is good, and the alveolar process fullness is good. All right, so this gives me a PES score of 11. 12, 13, 14 is excellent. 9, 10, 11 is good. 6, 7, 8 is acceptable. And anything under 6 is an aesthetic failure. Okay, so that's generally how we look at that. So in this systematic review, I looked at a number of papers, and some of the papers gave me raw information about the aesthetic outcomes. I could look at the PES score. So at the time, these were the studies that reported on PES outcomes. Now, this is not in the paper, okay? It was not published like this. I used this for the presentation and compiled the information. And so we look at the average pink aesthetic score of the different studies. So this is the mean or the median pink aesthetic score that was shown in these papers. And you can see most are in the acceptable zone. Most in the acceptable zone, 9, 10, 11. Some of them are in the excellent area on average. Some of them also in the poor area. Now, you cannot compare these studies one by one because some of them are in healed sites, some of them are in grafted sites. So the studies are different, okay? The populations are different. But it starts to give you a feeling of what aesthetic outcomes other people are reporting in the literature. Now remember, this is the average score. Some papers provide more granular information, and I was able to do a much closer analysis of the pink aesthetic scores. So these are, in these studies, the proportion of cases with excellent outcomes. 12, 13, 14. 12, 13, 14 is the excellent outcomes. And here are the acceptable outcomes, and here are the poor outcomes within each study. So this is now a frequency analysis. This gives you a much better picture. Because when you look at mean results, it doesn't tell you everything. The details are hidden because of the mean values. So you can say that, well, excellent is about 30% of the time, acceptable is about 50% of the time, and poor is about 20% of the time. So now you go back and look at the cases you treat. And when you're very critical with what you do, does it fall into this kind of pattern? And most of the time it's okay, it's good, the patient's happy. Sometimes it's really good, you take lots of pictures, right? Put it on Facebook, right? Or you use it in the presentation. And sometimes they are poor, and we don't want to think about that. And as long as the patient's happy, you don't say anything, right? Because we just don't want to bring up the problems with the site. And very often the poor ones are because of inherent problems with the site or a surgical error. There is an error in the performing of the treatment. So why is there such a variation in this results? Why aren't we getting consistent results all the time? So now let's look at some of these studies that actually give me the raw data. So I can now go in and look at each of the parameters. And these studies, now I'm looking at the average of the PES scores for each of the 7 different parameters. And this is now the 80 percentile. Remember, maximum score is 2. So 1.6 represents the 80 percentile. So anything above 1.6 on a mean means that there's a good results. So you can see mesial papilla, distal papilla, mid-facial level, mid-facial contour, alveolar process fullness, soft tissue color, soft tissue texture. We are very, very good with these. The level and the contour. So if you have good gum soft tissue volume and you are careful with the design of the crown and the emergence, you can achieve really, really good outcomes in the level and the contour. Because we know this is largely to do with the prosthetic design. As long as you have more soft tissue to start with, in the design of your prosthesis, you can shape the soft tissues and get a good result. Okay, so the papillae fall down all the time. The papillae is under the 80 percentile. Right? It's roughly, in the 60 percentile range. And the distal papilla is always worse than the mesial papilla, almost all the time when you look at the outcomes. So what is it about the papilla? Is there anything we can do with the papilla? So we have to remember that the papilla is a developmental tissue. This is one of my sons. I've got one daughter and two sons. And this is one of my sons, and I took photos. I thought, I must do something and document the eruption of his front teeth. This is, he's 6 years old now, okay? And I want you to see the changes that take place as the teeth erupt and the soft tissue retract through passive eruption. And focus on the tip of the papilla, which is there. Okay, so he's having some braces done, and the teeth, he's now in his mid-teens. So, what happened to the tip of the papilla? The tip of the papilla stayed behind as the soft tissue is retracted. And the shape of the papilla, the position of the papilla, is determined by the teeth. So as the teeth erupt. So your papilla is developmental. It's a developmental tissue. It doesn't grow down. The papilla stays there as everything, soft tissues change around it. Okay? So that's really important to understand. And that's now 21 years of age. Adult proportion of the teeth. The mammella have disappeared because of normal wear and tear in the front teeth. And that's the situation with the dentition. So remember, the dental papilla is a developmental tissue. So the papilla is tooth dependent. And if you look at the interdental region between two teeth, then there are the interdental fibers, the collagen fibers, and then there are the dentogingival fibers that go into the papilla itself. And when you take out a tooth, let's say we extract this tooth, the collagen fibers are in tension, and the collagen fibers retract back to where it's attached. Right? You have a spring, you release it, it pulls back. So it's pulling back to the tooth. And so you can expect everything to change and retract. Now let me show you a series of photos to demonstrate this. So this is a patient that I treated many years ago, and I just happened to have this nice sequence like this to be able to show you. We're taking out this tooth with a flapless extraction for a flapless immediate implant placement. Okay, but that's not important. I just want you to look at the soft tissue changes. Okay, we draw a line for using the right central incisor as the reference, soft tissue margin and the incisal edge. And then we take out the tooth and then place the implant. 20 minutes, right, from extraction, preparation, immediate implant flaps can be relatively quick. But look at the change in the papilla. Instant change in the papilla, why? Because the fibers pull back to the tooth. So this is a physiologic change that takes place because now the dentogingival unit, that developmental functional unit, has been disrupted by the extraction of the tooth. And now this papilla belongs to the tooth next door, but in a changed form. So the question I asked Dr. Lam, if we place an immediate provisional crown, can we keep that peak of that papilla and stop it from retracting? The studies will tell us if we do an immediate provisional, we have a better chance of supporting the soft tissues, but they still shrink. There will still be shrinkage taking place. So for us, one of the things we cannot fight against to a large extent is how the papilla reacts after a tooth extraction. And then if your extraction is a little bit careless, you're a little bit rough, you open a flap, you don't support the soft tissue, then it's going to change even more. You do multiple surgical procedures, it's going to change even more. Okay, so we have to understand that this is one of the limitations we have when it comes to aesthetics, and that's with the papilla. So prosthodontically, what do? We make the implant crown a little wider. Yeah, we make it a little bit wider to close off the space. Maybe we veneer the tooth next door to keep the symmetry. So we resort to prosthodontic tricks, prosthodontic techniques, the way the light hits the tooth of the crown, just so your eye is not drawn to the papilla, for example. So there are ways of not solving, but reducing the effects of what we see in the papilla. Okay, so what about the other side? The soft tissue color, texture, and fullness. these are all related, because if you have good alveolar process fullness, you usually have good color, and you usually have good texture. And you can see the average pairs is almost the same. That's why in Professor Bell's modified pink aesthetic score, he combines these three into one variable. But for now we use the three variables. So you see that we also are not as good in this when you compare it to the mid-facial mucosal level and the contour. So what's going on here? Well, the problem is we don't take care of the alveolar process fullness. So this is a tooth, implant placed 10 years later, no GBR is done, no contour augmentation is done. This is an extraction, post-extraction changes because I did nothing to change things, to stop it from happening. So we see these post-extraction resorption changes that take place. And of course, immediately when you have that, brings down the overall PES score because the alveolar process fullness is not there. And look at the color. So the color changes too because the soft tissue is thinner. And you also have a concavity. So when the light hits it, it's not going to look, the soft tissue is as bright and as pink. Right? So color, texture is not as good as the natural tooth. And so they all relate together. So if we cannot do much with the papilla except to minimize the change, it's this area that we can do a lot to reconstruct, to build back the shape and the volume, to get a better aesthetic outcome. Okay, so of the 7 parameters, mesial papilla, distal papilla, we try to minimize the change. All the others, we can have a positive effect by the treatment that we provide, by our intervention. So, when it comes to this fullness of the soft tissue, there are 2 tissue components that we need to look at. And it's what Zucchelli refers to as the connective tissue on the facial aspect of the implant. And we have 2 types of connective tissue on the facial aspect of the implant. We have a mineralized connective tissue, which is bone. Then we have a non-mineralized connective tissue, which is the peri-implant soft tissue or the mucosa. So it's the combination of these 2 which are important in achieving that outcome with the alveolar process, fullness and the color. So we need to consider these 2. So what are the requirements to get a good aesthetic outcome? You need thick facial bone. Now I spoke about the 1.5 millimeters of bone in a heel site this morning to maintain bone levels. This is different. This is now not just bone for the integrity of the implant, but it's also to maintain the fullness of the soft tissues. So you want thick soft tissues, you want thick bone to support the soft tissues and to then try and replicate the root eminence, that convexity of the prosthesis in that critical 4 to 5 millimeters of that soft tissue zone at the coronal region of the implant. So what do we know about this facial bone? Well, when CBCT came about, widely started to be used about 10 to 12 years ago, suddenly all the CBCT studies, suddenly people can see bone without having to open up a flap. Fantastic, now a great research tool. So studies after studies after studies looking at CBCT for both bone thickness, both soft tissue thickness, the phenotype. And that's another interesting one to look at, the relationship between soft tissue phenotype and bone phenotype. So that's a completely different lecture to talk about, but it's also one that's very interesting and helped by the fact we have CBCT to do this. So you see on this CBCT, facial bone not detected. Facial bone cannot be seen. Facial bone can be seen. Okay? Now I showed you the cases this morning, I'll show you some others. If you do not see bone on this area here, you cannot conclude there is no bone, because the bone could be very thin, and we simply cannot see it because of the metal article. What we can say though, if you see it, it's there. So CBCT facial bone is very specific. It's very specific, but it's not sensitive. In other words, it will not pick up small variations in the bone. So from a clinical point of view, if I'm treating a patient, I want to try and build it up so I can at least see the bone and I know it's there. Okay, we'll talk about that a little bit later. So here is a case sent to me recently. The patient's very unhappy with the color of the soft tissue, not happy with the shape of the soft tissue. So we're now thinking about doing a soft tissue graft, bone graft, or a combination of the two to change the concavity to a convexity. Okay, so of course I take a CBCT scan to see what the bone condition is like, and we see no bone. What we see though is thick soft tissue. Right? There is some thickness in the soft tissue, yeah, but there doesn't seem to be any bone. Open up a flap, there is bone. Bone is there. So this was an implant placed into a site. Nothing is done to stop the resorption. So this is one of those, do nothing, graft augment. This is the do nothing, and this is what happens over a period of time. The implant's been in place for 10 years. So don't trust CBCT data to say there is no bone. There almost always is bone. Now you have to make a decision. Do you augment this in bone? Do you augment this in soft tissue? So if you're the GBR camp, the Professor Danny Bruises, you go with bone. If you are the Giovanni Zucchelli, then you augment in soft tissues. I'm kind of in between. I like to have both bone and soft tissue, so I try to do both. I don't think one is right or wrong, because this implant is healthy. No problem with the bone support on this implant. The only problem is that it does not have that volume of connective tissue, whether it's mineralized or non-mineralized connective tissue. Okay, so I think this is a concept that we have to start to think about, and it will be addressed in the ITI consensus statements that are coming out this month, talking about the mineralized and the non-mineralized connective tissue for aesthetics. So I showed you already this morning that we want that minimum of 1.5 millimeters for maintaining bone integrity. Yeah. Now, native bone. When you put an implant into the original bone, in the anesthetic zone, the first thing you have to understand is you cannot rely on the native bone to maintain the facial bone dimensions. This is part of a clinical study that I did in the early 2000s, part of my PhD thesis, immediate implant placement with different grafting materials, autogenous bone, bovine bone mineral, and so on, and memory. This is just an example. So an immediate implant and a re-entry after 6 months. And this was one that was grafted with autogenous bone chips. It's all resolved back. The implant's perfect, but you cannot rely on the native bone to hold the bone out there. The bone will resolve up to the implant and then it will stop. It's not like a tooth. It won't keep that buccal contour. So of course we get the flattening of the ridge. And those bone remodeling changes post-extraction take a long time before it's seen in the soft tissues. So this is an immediate flapless implant that I placed in 2004 with no bone graft. Back then, we thought there was the distance of 2 millimeters, the bone would naturally fill in the jumping gap. That was a big mistake that we made back then with our very early understanding of bone regeneration. The bone may fill in, but the bone also shrinks and resorts back to the implant. So 2007, 3 years later, it looks great. So if you just look at this time frame, you think, well, I'm going to do every implant, flapless implant, no graft. Why? Because I get a beautiful result. But you have to wait 7 years before you start to see changes. 7 years before it starts to recede. And then 1 more year later, it's gone. Okay? So here I say the same thing again. If you are doing a new technique today, you have to wait 5, and I'm talking about aesthetics now, 5, 6, 7, 8 years before you can really say this is a predictable procedure or not. Because you will not see these changes in a short period of time. So this is immediate implant placement. And we now have data. Joseph Kahn has published a study with immediate implants, immediate provisional prosthesis. And the 1-year data showed that in thin biotype cases, thin soft tissue phenotype, it receded 3 times more than the thick. And the combination, as you can see here, combined thick and thin, was just over half a millimeter after 1 year. Okay, but he didn't stop there. He reported the data after an average of 4 years. Kept going. Okay, so this is the whole point that I'm trying to make, is it does not stop after one examination. The changes are progressive, unless you do something to intervene to stop this from happening. And that's where today, with our understanding, we can do this now. We can do this with high degree of predictability. And this is a case shared to me by my colleague Anthony Dickinson, who's a prosthodontist in Melbourne. Sorry, I have to sit down now, my back is playing up. So if I sit down, can you see? Can you see? Is it, am I blocking? Okay? Yeah. All right, so this is an image from Dr. Dickinson, and this is early implant placement, another case that he treated with another practitioner. So the tooth is extracted, 8 weeks later the implant is placed, but no GBR is done. Nothing is done to reconstruct the bone, it's just putting it into a healed site. And you can see the changes that take place. The implant is not facially malpositioned at all. It's the right central incisor, that's the dental implant. So it doesn't matter whether it's immediate implant placement, early implant placement, late implant placement. The timing of the treatment actually is not the criteria. The criteria or the clinical criteria is whether anything is done to stop the resorption from taking place by grafting methods. And here's the late placement. This is a patient that I treated 2003, 5 years later. I placed the implant into a healed site, no grafting. And 5 years later, we get these changes. And now let's take the crown off because I'm able to graft this. I cannot tell you how many cases of mine I've had to come back and graft with hard and soft tissue throughout the 20s and into the early 2010s, 2015s because of the treatment I provided 10 years previously. So I don't want any of you to make the same mistake by repeating an error over and over again until you learn when you start to see the consequences many years later. Don't repeat these mistakes that we have made. We have learned from this and we must prevent this from happening. So what do we need to do? You need to reconstruct the facial bone mold. So if you're talking about bone and you cannot rely on the native bone, you then have to reconstruct it with a biomaterial that does not resorb, that volumetrically will remain stable over a period of time. Okay, so you can see the implant goes in, this bone is thin, will it stay there, will it not stay there? We have to think about grafting it. So my early research looked at different biomaterials, and what we found was that deproteinized bovine bone mineral, DBBM, which was the only bone substitute available to us in Australia for a long time. We had no allografts, were not allowed. We couldn't use allografts. We could use autogenous. We could place the implant with a blood clot and just leave a gap, or we could graft the socket. So what was shown clearly in this study, which was a randomized controls study of non-submerged immediate implants. In other words, these are implants placed transmucosally. Flaps were opened with this, and then a re-entry was done. Today, you cannot do this study again. You cannot do a re-entry in an aesthetic site. They will never allow you to do this in the ethics board anymore. So studies like this 20 years ago that were done are actually very rare, and the data is very important that we continue to refer back to it. So you can see that if you look at the orofacial resorption of the ridge, that if I placed DBBM or I placed DBBM additives, a collagen membrane, we had the least amount of resorption of the facial bone. Whereas if I did a blood clot as a control, I had almost 50% horizontal resorption. So we knew from 2007 that deproteinized bovine bone material had this ability to be volumetrically more stable. And now there are many brands on the market. And if you're looking at a bone substitute, what you need to analyze is the data on whether it resorbs or not. Because if it resorbs and is replaced by natural bone, it's great, but it's no good for this type of procedure, for contour augmentation, because you want to rebuild this in a material that doesn't resorb. So what do we know? We know that DBBM retains a significant proportion of the graft material, very little resorbs. Once the graft particles are embedded in new bone, they almost never resorb anymore. It's very, very slow. And they are dimensionally stable over time. So I remember when, in the early 2000s, late 1990s, 2000s, when this material was introduced, We had some human histology after 5 years. One was, now you might remember, I think 9 or 10 years, and we could see the graft particles there. They didn't resolve. Everybody said, oh, this is terrible. This is very bad grafting material because it doesn't resolve. And then suddenly we turn around and say, oh, this is wonderful grafting material because it doesn't resolve. Right? So it's a complete opposite. So depending upon what you want to do and what you want to achieve with the graft. Now I want to share this study with you, which we published during COVID. Something we actually did, something positive. We wrote up the paper. The treatment was done earlier. So this is in a dog model, a canine model. And what we were doing was comparing bone level straight with bone level tapered implants in the maxillary second incisors in dogs. Dogs have 6 incisors, 6 maxillary incisors, and the second incisor is a similar size to a small lateral incisor in a human being. Okay? Primary outcome variable was the stability. Was there a difference between bone level and bone level tapered in the stability of the implants? Okay, so you can see the studied parameters. Flatness, immediate implant placement. Implant shoulder placed at the level of the buccal bone crest, grafted with DBBM and a collagen matrix, and then sealed over with a 3D collagen sponge. Exactly what you would do in clinical practice today if you were not doing immediate loading. Exactly the same. All right, so primary outcome variable, the bone level tapered implant had 10% higher ISQ at the time of placement. Okay, so the null hypothesis was dismissed, and we say that significantly better stability was achieved as measured by ISQ with a tapered design. So we know that today. Tapered design implants tend to get better stability in immediate extraction sites. But I showed this study for the histology. So this is one of the tapered implants. And the histology is, this is the buccal side, okay? And the green represents the DBBM particles, the graft particles. The bright red is the new woven bone. And what you see here is that you have a completely regenerated, so I'll go back, a completely regenerated facial bone wall. So this is now a completely regenerated facial bone wall at the marginal area of the implant. Okay? Now, the original facial bone has resolved at 1.5 millimeters. Remember I showed you that those papers, 1.5 millimeters vertical resorption, exactly the same, very consistent, 1.5 millimeters after flatness extraction. The horizontal resorption, remember the implant was placed 2 millimeters away from the facial bone. Now the newly regenerated crest is 1.5 millimeters. Why? Because we've lost the facial bone. Okay, so we have, although we now have the graft material in position, things have changed. Dimensionally, it is not exactly what it was before. So now I want you to focus on this area that I've circled. This is the supracrestal zone with the graft particles. See where the bone crest is. Look for the new bone that's formed around the green particles. So new bone is red, forming around the green particles. In this region here, almost no new bone, just graft particles. And why? Because it is no longer contained within a bone wall. This is 12 weeks in the dog model, 3 months. In a human situation, this would be 6 months. So this tells you in 6 months, you still have no bone on the mid-facial aspect of the implant, only biomaterial. It's in a non-vascular, fibrous connective tissue matrix, non-inflamed. The question is, will that turn into bone? Will that turn into bone over the next 6 months, next 12 months? Who knows? We simply don't know. And we know that that facial bone resolves very fast. And Vivian Chapman says that facial bone actually within 6 weeks is gone. That resolves very quick. So bone substitute graft not contained within the bone walls may not regenerate into bone. So what are the consequences? So this is an immediate flapless implant placement with an internal graft of DBBM. 2 years later, the patient has persistent redness in the facial aspect here. Persistent redness, we cannot get rid of it. So in the end, we open it up. No bone regeneration. Immediate implant. Where is the DBBM particles? You see one DBBM particle here. One there. That's DBBM particle there. And up there you see some DBBM embedded in bone, but nowhere else. So the bone has resolved. The particles, once the particles are in soft tissue, they resolve. Eventually they resolve. So this is the danger in immediate implant placement. If we don't understand what's going on, then this is a case perfect for peri-implantitis. And you wonder why we see so much peri-implantitis. If you place implants into thin bone and the bone resolves, if you place implants into extraction sites and they don't form bone, then of course we're setting the condition up for biological complications. So I want to share with you this study, a very simple study I published in 2017, the behavior of the facial bone after tooth extraction. 34 patients, maxillary, central, and lateral incisors. I measured soft tissue and the hard tissue. And I looked for the condition of the bone plate. These are not the patients in the study, because the patients in the study were all flapless implants. Yeah? But this is just to show you. The bone was either intact, there was a dehiscence, or a fenestration. Right, so 3 possible conditions when you take out a tooth. So if we have, of the 34, 16 cases had intact bone. And when we did the re-entry, I did the re-entry 8 weeks later, 7 were still intact, 9 had become dehiscences. And we call this now a V-shaped dehiscence. Typical V-shaped dehiscence that forms at the neck of the implant. 9 of the cases had dehiscence defects at the start, and at re-entry, all 9 had dehiscences on re-entry. So your dehiscence defect is the most predictable. Most predictable. Fenestration defects. 9 had apical fenestrations due to endodontic complications. I always thought fenestration defects are never a problem with immediate implants. Just clean it out, I can put the implant in, the bone wall still intact. In the 9 of the fenestration defects, 2 healed to become intact. 5 out of 9 became dehiscences. And when they became dehiscences because the coronal bone disappeared. And your dehiscence now is a huge dehiscence. It's a very big dehiscence because now you combine that dehiscence with the apical fenestration. 5 out of the 9, and 2 remain in fenestration defect. So 56% of intact sites became dehiscences, and 55% of fenestration sites became dehiscences. This is a major problem. A major problem because bone substitute graft not contained with bone walls may not regenerate bone. Okay, so we have to understand this. Now we take out a tooth, put an implant. Do you know what's happening to the buccal bone plate? We have no idea. Even a CBCT is not going to tell you. So we have some really big risks with immediate implants if we don't understand the underlying biology. Now with early implant placement, what we can do is we can rebuild the bone. Because when you take out the tooth, after 8 weeks, the bone resorbs and flattens off. And it flattens off, so now we can rebuild it back to where it was originally. We don't care about the buccal bone anymore. Doesn't matter whether there's a dehiscence, doesn't matter whether it's intact. We're going to graft over it anyway. Right, so this is the most user-friendly of the treatment approaches when it comes to reconstructing the facial bone. Because you simply reconstruct in the biomaterial right from the beginning. So here's a case. Upper right, obviously the upper right central incisor has to come out. You can see it's a major resorption case. Now when I look at CBCTs, what is the most important view for me? It's this axial view. This is the most important view because I can take a measurement of this to see how broad the ridge is and can I get an implant in and maintain bone walls. Remember we talked about bone walls. So now I know if I put an implant in 4 millimeters in diameter, I have 2 to 3 millimeters of the buccal bone still sticking out. That will become my bone walls. Right, so the implant is still within the confines of the alveolus. And these can be grafted very predictably. So here's 8 weeks after extraction, early implant placement, the typical flattening of the ridge that takes place. Yeah, but we still retain those bone dimensions. Very little change takes place in the proximal because that dimension belongs to the natural tooth. And all that flattening in the middle, we can rebuild with our grafting procedures today. So there's the big dehiscence on the facial aspect after the extraction. The implant is placed with a long dehiscence, but the implant is completely within the confines of the bone. So here is a very old study from 1999, Nicholas Zisman from the University of Zurich. He's a prosthodontist, by the way, but he did a lot of PhD based on grafting with DBBM and different membranes and so on. So here you see the 3 timing. Type 1 is immediate, Type 2 and 3 is early implant placement, type 4 late implant placement. And here are the proportion of no wall, 2 walls, and 3 walls. So with type 1 placement, you have a small number of cases with no walls, but a maximum number of cases in type 4. So completely healed ridge has a higher chance of having no walls. Whereas 2 wall defects are shared between immediate and early, and you almost never find a 2 wall defect in the healed side. Right? And then a 3 wall, in those intact bone walls in the extraction socket, is best encountered with immediate implant placement, not so much with early implant placement and late placement. And then she examined the corresponding regenerative potential. As the number of bone walls decreases, the predictability of the regeneration volume decreases. So this study clearly demonstrates that bone walls are critical in determining how successfully the GBR outcome is. So here's the same case now. Here's the same case. So you can see the implant from the occlusal point of view. It's in the bone confines. And the first thing that we do with the GBR procedure is you graft any exposed part of the implant with autogenous bone chips, because that will integrate very fast onto your implant. Now, I'm not talking about the bone that comes out of the drill, it's soft, like sawdust. I'm talking about big bone chips. So what I do is I chip away the anterior nasal spine, the surface of the bone, and I get large bone chips, because these will integrate very rapidly. Because you want natural bone on the implant. And then you overlay that with your biomaterial membrane, and then you complete the GBR procedure, right? And that's the reconstruction of the shape of the ridge. This is a 5-year outcome with the GBR procedure. Papillae are looking good. The papillae are still looking good, and do you know why? I'll show you. You see the papillae on the palatal side? I do not raise the palatal flap. I leave the palatal tissues attached, and I try and find the mid-palatal bone just to know where it is, but so I don't disturb the blood supply coming from the palate. And then when the flap is closed, we make sure we suture very closely the papillae of the buccal flap to the lingual flap. And this way you can minimize the shrinkage of the soft tissues. Okay? And the CBCT showing thick facial bone and the bone coronal to the implant shoulder. This is what we want to find every time. I'll come back to that in a moment. So, number 3 was we need to reconstruct the facial bone thickness, either immediate or with early implant placement. That's the primary outcome. Then we want to reconstruct the facial bone so that it is now coronal to the implant abutment interface. So you see here, the dotted line is the shoulder of the implant. The bone peak is coronal. It's built coronal, and then you have the soft tissue, biological, which is another 3 millimeters. Okay? So now you have biologically sound, final soft tissue, hard bone relationships. And so this is what the aim of treatment should be for every case you do. And here's a study that our group published with one of our postgraduate students looking at immediate implants submerged versus transmucosal healing. Once again, in the second incisor model. We published this in 2014. So you see the histology for the submerged, transmucosal. The red arrows are the facial or the buccal side. And there was no difference between groups in terms of the bone regenerative potential. So non-submerged is blue, red or pink is the submerged, and I superimposed the two. So the shape and regeneration looked the same. But when we looked at the histology, that 1/3 of the implants didn't regenerate bone to the crest of the implant. Okay, so we failed to regenerate bone height, irrespective of whether it was submerged or non-submerged healing. And this has everything to do with how rapidly that facial bone resolves with an immediate implant. Okay, I'll come back to that later. So we have to understand that in an immediate implant site, the thin bone is the one that's at risk, because thin bone will resolve vertically 3 times more on average than thick bone. The problem, of course, is most of the time in practice we only find thin bone. You almost never see thick bone in the maxillary anterior region. And therefore, one way to mitigate this is with immediate implant placement. What I try to do is I place the shoulder of the implant, when the bone is intact, I place the shoulder of the implant under the bone crest by 0.5 to 1 millimeter to compensate for that 1 to 1.5 millimeters of resorption that's going to take place. And the thinner the bone, the greater the risk, as I already mentioned. Now there's new data now to show the importance of the gap width in a paper published by Bob Levine in 2022. Because this has a huge impact on how you retain bone height with immediate implants. So this was a CBCT study, a retrospective study, looking at the outcomes. So in 41 patients, 17 of them had a buccal bone gap of 2 millimeters or less. 2 millimeters or less. Not less than 2 millimeters, but 2 millimeters and less. And you can see this is the buccal bone gap. And all these implants are implants placed with intact bone, flapless placement. Flapless placement and immediate provisionalization. And 34 sites had a buccal gap greater than 2 millimeters in dimension. And all of them were grafted with DBBM. So this is just a schematic of the results on the thin side, on the less than 2 millimeters and the more than 2 millimeters. So where the buccal gap was more than 2 millimeters, the residual CBCT bone was 1.7 millimeters in thickness. And on the less than 2 millimeters or less, it was 0.5. And once again, doesn't mean there was no bone there, but it was probably very thin and couldn't be seen on the CBCT. And importantly, the bone height was coronal to the implant abutment interface on the wide gap compared to the narrow gap. I used to think 2 millimeters was wide, but 2 millimeters is not wide enough. You actually have to have more than 2 millimeters, because what you want is the biomaterial to completely occupy that space, a provisional matrix to form, and all that to regenerate into bone. And if it's too thin, it won't happen. We need the bone thickness for the blood clot to form in the DBBM material. So now we're starting to understand that these dimensions become very important. So with immediate implants, if you want good bone height, more than 2 millimeters of space. Okay, if you want to have a better chance of retaining the buccal bone thickness. So more than 2 millimeters between the implant platform at the shoulder and the inner surface of the facial bone wall with immediate implants. Okay, with intact facial bone. This avoids, firstly, implants being in a facial malposition, and it provides that space for the regeneration of bone. So when you put a bone graft into the socket, it fills with a blood clot. The blood clot then has to reorganize, and then new bone cells come from the periphery. Bone cells grow from the side, that way, and that way, not from the front. The facial bone is too thin, there's no trabecular space. So all the bone regeneration is from the side. And when you have the implant far back enough, and there's enough space, you get more chance for bone to regenerate into the side. The less space you have, the less space there is for the bone cells to regenerate. It's all to do with the proximal bone walls. You're doing a lot of proximal bone walls. Sorry, what did I just do? Okay, so this is the orofacial position of the implant shoulder. All right, so here's a case with an immediate implant, the upper left central incisor. The implant's been placed, flapless extraction. The implant's placed with a greater than 2 millimeter gap, grafted with DBBM, and here I just sealed it in with a gelatin sponge. Not immediate loading. This is conventional loading. The patient is quite happy to continue with a small partial denture. And this is after 12 weeks. So look at the facial bone. That's really, really nice. Now it doesn't stay like that, yeah? Because that's just DBBM material that looks radio opaque. So we have to see what it looks like after 2 years. So that's retain the thick bone and see where the crest is. The crest is coronal to the implant abutment interface. And you can see the left central incisor from the facial and the occlusal. Look at the contour of the ridge. So that's what we want with our immediate implants. Okay, we want to try and do that every time. Have it 8 years. So it lasts and it survives. And the volumetric stability is what we really want to see. Early implant placement, the biological objectives are exactly the same. Okay, so you have tooth is extracted, the site is allowed to heal for 8 weeks, and after healing you get this soft tissue thickening that takes place. You do get the flattening of the ridge, and now when I re-enter the site to place the implant, I can now place the implant in the correct position. I place a healing abutment to support the soft tissues when it closes, and also to support the graft as well. Autogenous bone chips in the middle here. So this is autogenous bone here. So you can see that they're locally harvested, right, just straight from the area, and then covered with DBBM. And then a barrier membrane, double membrane. Coronal flat advancement. I don't need to get primary closure. Partial submergence is sufficient. But you can see where the graft is placed. The graft on the right-hand side is placed coronal to the implant abutment, halfway to 3/4 of the way up the healing abutment, because we want to reconstruct the bone height. Okay, so there's the case after 3 months of healing, and now we have 3-year outcome with nice soft tissue contour, good contour on the contour augmentation and in the base called that facial contour, and then the CBCT once again showing thick bone, thick soft tissue, bone crest coronal to the implant abutment interface, 3 mm biological width. So whether it's an immediate implant or whether it's early implant placement or late implant placement, this is what you want to achieve for your aesthetic outcomes every time. And this will provide you with stability. So this is the same case now 9 years later. Stable. Okay? So I come back in 10 years and tell you what it's looking like after 19 years. But I think I can be pretty sure that this is going to be quite a stable situation. So we know from one prospective case series study done by Danny Bruce's group with early implant placement in GBR, that in this case series study of 20 patients followed for 10 years, that if you provide the correct treatment philosophy, then when you look at the CBCT and the soft tissue changes around the implant, and you document them over a 10-year period. In the paper, they show every case, and the CBCT for every case, so nothing is hidden from the viewer. We know that this is stable for 10 years. And colleagues, this is the only paper that's got 10-year outcomes with reconstructed or regenerated bone, whether it's immediate implants or GBR, using DBBM for 10 years showing soft tissue and hard tissue stability. Right, so all those proponents out there of different techniques, immediate implants, socket shield, partial extraction, they're all fantastic, but we need 10-year data to tell us is this stable or not. Okay? Until we get the 10-year data, and it's still an experiment. I believe it's still an experiment with some of those different techniques. Okay, the implant design to maintain the bone marrow. I already mentioned this paper that we published in 2013. So you can only rebuild the bone coronal to the implant abutment interface if you have an implant design that doesn't form a saucer. Okay, so there's no saucer formation. So it needs to maintain the bone. What we need is one, an implant with internal conical abutment, and that is tapered. And the taper needs to be under 45 degrees. The narrower the taper, the tighter the connection, the better it is. That then provides the platform switching of the abutment into the internal side of the implant, and also the microgap is internalized. We also provide that stable implant abutment junction, which doesn't flex, and an osteoconductive surface like the SLA or SL active surface. These are the requirements to be able to grow the bone. And I already showed you the bone and the microgap debate. Okay, so alveolar ridge preservation with socket grafting. Can this, in the aesthetic zone, help us? So a paper that we published There was a definition that we published in 2008. This was part of a systematic review we did for the ITI Consensus Conference in 2008. And I think it's still a good definition today. So people call it alveolar ridge preservation, ARP, or sometimes we refer to now simply as socket grafting, because we know we actually don't preserve the ridge. It does still resolve. But it's a procedure undertaken at the time of or soon following extraction designed to minimize the external resorption and maximize the bone for the subsequent placement of the implant within the socket. Okay? So it doesn't have to be done straight after the extraction. Sometimes you have pathology, you need to come back at a later time, but you can still do the same procedure. So this is a paper, another paper we published during COVID. So the treatment was performed a couple of years earlier, we wrote it up. So what I was doing was saying, okay, everyone's talking about grafting into the sockets, and I know lots of my colleagues are grafting sockets in aesthetic areas because they believe it gives a better bone volume for an implant. Okay, if I take out a tooth and I do early implant placement, I come in at 8 weeks, yeah? And then I wait 3 months and reload. So the case is done in 2 months, 3 months, 5 months. If I do socket grafting, they say wait 3 or 4 months. Then place the implant, wait another 3 months. Now we're looking at 6, 7, 8 months of treatment. So what I wanted to do was to push the envelope and see if by grafting the sockets, I could come back at 8 weeks for early implant placement at the same time frame for early implant placement. And that means the timing is no longer a factor because the timing is the same in the two techniques. The only difference in the outcomes. And I was able to do this because there was some histological data in animal studies and one clinical study which said, yes, you can do this at 8 weeks. Okay? So it wasn't something completely new, but the study design was different. So what I chose to do was to take 10 consecutively treated patients, maxillary, central incisor, only one tooth type, maxillary, central incisors, grafted the socket with DBBM in a collagen matrix. So it's embedded in collagen, and then sealed in with a collagen, porcine collagen sponge, and then re-entry 8 weeks later for early implant placement. So here is one of the cases. What you see here is the tooth undergoing resorption. My colleague Anthony Dickinson cut the crown off, and he just used a little bit of trichloroacetic acid just to control the bleeding, and he delivered the patient a partial denture to sit over the root. So then the patient comes to me for the treatment. So the first thing I want you to observe is when you look at the occlusal view, look at the contour of the ridge. It's very prominent, isn't it? So we've got these premaxillars that are quite prominent and tapered. These are the nightmare ones, because when you place your implant, can you recreate that contour back again? So always look at the occlusal view when you analyze your cases. So here's the flapless extraction, confirming that bone walls are intact, grafted with DBEM, and I graft up to the level of the facial bone crest, up to the palatal bone crest. I don't graft beyond that, because you need to maintain 3 millimeters of soft tissue height for your soft tissues to regenerate. So don't overbuild the graft. And then on the right-hand side, you see the collagen sponge, the porcine, the right collagen sponge, switching into position. Of course, there was bleeding into it, so it was already forming a blood clot. And what I did was I took measurements externally, and I did bone sounding measurements to take measurements of the bone dimensions. And then I repeated this 8 weeks later when the implant was placed. It's a very simple study to examine the dimensional changes. So, time of surgery, 8 weeks. We can see the soft tissue is healed, but can you see a flattening that already happened? Despite the grafting, there is a flattening of the ridge on this facial aspect here. Okay, and that's because the supracrestal tissues from the bone crest to the gingival margin, when the tooth comes out, collapses. So even though I put a collagen sponge in there, it still collapsed. One of the reasons we place an immediate provisional crown is to try and stop that collapsing from taking place. But in this type of approach, you don't have a chance to do this. And then some people say, okay, why can't I now do a flapless placement of the implant? Well, the problem is there's the flattening of the ridge. I have to correct that. And the only way I can correct that is to open the flap. So all of these cases require open thickening of the flap. So what are the changes that took place between here and here? Proximally, almost nothing. No significant difference. Half, 0.1 to 5 millimeters, 0.5 millimeters. But in the mid-facial, 1.5 millimeters of facial bone resorption from the buccal side in the middle. Now, not much, but in an aesthetic situation, that's a lot. That's a lot. Okay, and this is now the re-entry. Bone is filling in very nicely, but we can see some changes that have taken place. So from a bone point of view, we have very little change in the proximal bone, but in the mid-facial bone, 0.7 millimeters. So if I go back here, the mid-facial soft tissue is 1.4, mainly from the facial side. The bone is only 0.7, half. Doesn't add up, the maths doesn't add up. The difference is the collapse of the soft tissue after the tooth is taken out. Yeah? So it's not just the bone, it's how we deal with that supracrestal soft tissue that becomes important. And have a look at the vertical change. So the grafting did not stop the vertical resorption in the mid-facial region. No significant change in the proximals, but we had that 1 to 1.5 millimeters in the vertical plane. Consistently happens every time. Every study you look at 1.2, 1.3, 1.5, even with the graft. So we have a problem because the graft does not stop the facial bone from resorbing. And when the facial bone resorbs, the graft is no longer contained. So here are the CBCT analysis that I did. We saw that the change in the orofacial width, everything changed horizontally. And there was a volumetric change in the cross-sectional area of about 10 to 12%, mostly in the coronal area. So alveolar ridge preservation does not preserve the alveolar ridge. That's why it's the wrong terminology to use. So I don't use that term now. I say it's a graft, a socket graft at the time of extraction, and we do that to minimize the resorption. We know it's still going to change, but we then have to deal with it later. Okay, so let's have a look at the same case now. So now I opened the flap at 8 weeks, and now I'm placing the implant. And yes, I can drill into it. The graft material does not scatter because it was embedded in the collagen matrix. Much, much better to handle than particulate graft. So DBBM and collagen matrix, clinically, it was much better to handle. And you can see it's maintained some nice thickness of the bone on the facial aspect, but not in this critical area here. The critical area here is where I need the support. And that bone is missing. So what I had to do in every case, in all 10 cases, I had to do another graft. I had to do another graft and build up the contour and the height second time. Okay? So now I ask the question, if I had just taken out the tooth and come back 8 weeks later, I only need to open up one bottle of graft material. Now I open up one packet at the extraction, and now I come back, I open up another packet. Doesn't make sense. So to me, it doesn't make sense in most cases to do a socket graft in situations where I know I'm going to come back 8 weeks later and we'll need a graft. So we go through the GBR procedure once again. Okay, I'll just quickly go through this. So there's the results. And once again, looking at the occlusal view, there is some flattening. You can see some flattening has taken place here. And on the PES score, this will be a 1. It's not perfect in terms of reconstruction. So even with 2 grafts, I'm not being able to build it right out again. This is 2 years, and you can see very high smile line, very high aesthetic demand. Okay, but it's looking clinically quite reasonable. So, socket grafts will reduce but not eliminate the horizontal and vertical resorption of the ridge. And why is this? We place our graft into the socket, and we cannot influence the resorption of that facial bone. That bone will disappear. And you have the bone disappearing, and then the collapse of the soft tissue as well. Okay, so we have to rethink this whole strategy of socket grafting in aesthetic areas. If you're not going to come back for 6 months because the patient is traveling or COVID interrupted things, yes, I think it's very important to graft the socket. But if you know you're scheduling the time 8 weeks later, I cannot see really a major advantage in grafting the socket in most cases. So now we move on to the soft tissues. So I spoke at length about the bone and the thickness of the bone that we need to recreate. What about the thickness of the soft tissues? Well, we need a minimum 2 millimeters thickness of marginal soft tissues. Thickness, orofacially. Why? Because if we get any inflammation at the junction between the implant and the abutment, and this is Verhoek's observation in 1976. So you have to remember this is on external hex implants where you always get a microgap issue. It said if you have the thickness of the soft tissues more than 2 millimeters, that's greater than the inflammatory infiltrate. And therefore, you don't end up with a fistula. Instead of a fistula, if you get an infection, you get pus coming through, or infection coming through. So, this is the rationale back then. Makes thick soft tissue so that when it gets infected, it comes through the gums and not through the hole in the gum. It kind of doesn't make sense. But today, I think the same argument applies. If you have thick soft tissue, then you're going to get much better chance of resisting any mucositis that might occur around your aesthetic implants. And the other reason we need the thick soft tissue is to mask the metallic show through. So if you've got more than 2 millimeters, then you're going to mask any metal that's under the soft tissues, provided the implant's not in a facial malposition. And we know we need thick tissues to prevent recession. Okay, so irrespective of the bone, we need the thick soft tissue. So remember, we need connective tissue on the facial aspect. And the connective tissue, I'll repeat again, can be mineralized and non-mineralized connective tissue. And preferably you have both, and both are thick. So for immediate implants, if you can, select cases with thick gingivae and thick facial bone. In Melbourne, where I'm practicing, I may see 2 patients every year. 2 patients every year that fulfill this criteria. The rest have thin bone, thin soft tissues. In Vietnam, anyone with thick tissue phenotypes here? Almost never, right? Almost never. So everyone stands up, talks about, thick tissue, completely irrelevant to this part of the world. I'll tell you a story. When we first bought our CBCT machine, the first one we bought the Morita R100 in 2013. So I was the test guinea pig. So I go into the machine and it does a full mouth scan of me. I looked at my scans. I'm bimaxillary protrusion, bimax. Thin soft tissue, thin facial bone. I went, oh my God. If I ever had to have a dental implant in my front, I'm at such high risk of soft tissue recession. So you go, oh. So, this is the reality. We have the majority of our patients don't have this situation here. Thick bone and thick soft tissues. So unfortunately, it's not the common situation. So what you have to do if you're still going to go ahead and do an immediate implant in these situations, well, you have to prevent the collapse of the soft tissue. So we use a provisional crown, but then you have to thicken the thin soft tissues, because if you take out a tooth, place an implant, put a provisional crown, if it's thin, it stays thin. The phenotype doesn't change, and then it resolves. So not only do you have to graft, but you have to thicken the soft tissue, either with a CT graft or with a soft tissue substitute of some kind. But you need to do something to thicken the soft tissues. The CT graft can be in the marginal area, or it can be an interstitial graft. If some people are doing this split thickness on the outside of the bone, I don't know how they do it. I can't do this. I can't stretch the tissues enough. But it's been shown. Or you raise a flap, and you raise the flap if you have to repair missing bone, and then you place the connective tissue. Okay, but now you're starting to make things very complicated, and you increase the risk when you start to have to do all these procedures. And I was with Stephen Chu, who's the prosthodontist from New York, works with Dennis Tana. So we lectured together in Singapore about a week ago, and they have this dual zone technique where they graft they graft into the bone area, a larger part of the graft, and in the transition zone here, they actually graft small particle graft. Now that small particle graft gets incorporated into the soft tissues. And I think it thickens the soft tissue because now we have fibrous connective tissue growing around the graft material, which eventually resolves. I asked them, please give me histology. There's no histology on this technique. Yeah? But they reported outcomes. So basically, if you've got thin tissue, thin bone, you have to do something to address the soft tissues. Now you increase the level of complexity of the treatment. So in cases of minor damage to the facial bone, the ITI, in its consensus statement, will say to you that in an ideal situation, taking out the tooth, placing the implant and grafting the gap, and placing a provisional crown is now the standard of care. Right, so the ITI has completely reversed its recommendations. If you have the ideal conditions, because of such high patient-centered benefits, you should really be thinking about an immediate implant. But the issue is, though, you have to understand the risks that are involved. And if you have minor damage to the bone, then you almost have to lift the flap back. Remember, we're dealing with thin tissue. So you have to do all these adjunctive procedures, which I was doing a lot of over the last 20 years. Today, I don't take the risk. I do these as early implant placements. Yes, you can do immediate implants. You have to coronally advance the flap, you've got to graft, but is it worth the risk? For me today, I don't want to take the chance. So I look at alternative options in these complicated cases at early implant placement. Okay, so I've done many of these in the past, most successfully, but sometimes not successfully. And here is where I ask you a question. I usually ask the audience, what level of risk can you tolerate in your practice? When you're dealing with aesthetic cases, if you do 100 cases, can you accept 5% complication? That's 5 patients with aesthetic complications. Can you accept 10%? Definitely not 10%. 5%. 1%? One patient with aesthetic complication. For me, I want 0% aesthetic complications. I do not want to deal with a patient who's got an aesthetic complication that I've created. So in my later part of my career, I've been placing implants for more than 30 years. In the later part of my implant career, I am so against risk. Right? So these cases, yes, I can do them, but I will not do them today because I see the risk is being too great. So the early implant placement provides automatically the thick soft tissue. So when you take out the tooth, the thin phenotype reverts to a thick phenotype. Yes, you get the collapse in the ridge, but there's an automatic thickening that takes place. And now we can manage this with our early implant placement. And we know this from the study by Vivian Chapuis and Danny Bruiser from the University of Bern. So they took out teeth in the maxillary anterior region, and the CBCT taken immediately after extraction showed how thin or thick the bone phenotype was. So you can see here very thin bone and very thick bone. And then when they went back 8 weeks later to do the implants, they took another CBCT. Here you have no more bone. Battery?
Nothing.
So when you turn this one on?
Oh, nothing.
So here we have to wait after 8 weeks, and you can see here the bone has resolved, and following resorption of the bone, the soft tissue is thickened. And in this case here, the thick bone phenotype here, 8 weeks later, it's still thick. And now you have less bone thickness, not soft tissue thickness, because the bone didn't resorb. So remember we said thin bone is no good, oh terrible, because thin bone resorbs. Now we're saying thin bone is good. Thin bone resorbs, soft tissue is thicker. If I have thick bone, then in fact I don't get as much soft tissue thickness. So if you turn it around, you now work to your advantage. So thin bone phenotypes, in fact, are advantageous when you're dealing with early implant placement because you have enough time to allow the soft tissues to thicken. Also, most of the teeth that take out have infection. Rarely are they perfectly pristine teeth. There's something wrong with the tooth. Apical infection, vertical root fracture. The ones that you can do immediate implants are those that have a crown and lost retention. And basically, those are the ones with intact, pristine, surrounding bone and soft tissues. So we like this. So if the bone is thin, I showed you this X-ray, the CBCT earlier in the presentation. This is the same case. No bone on the CBCT, but perfect aesthetic result after 22 years. Why? Because the soft tissues are thick. And we had this discussion today, yeah? So, I'll repeat again. You need thick connective tissue on the facial aspect. If you cannot have thick bone, then you must have thick soft tissue. It's better to have both if you can. So, support the soft tissue with an immediate provisional crown if you're doing an immediate implant. So this is a case I treated with Anthony Dickinson. You see the CBCT shows a thick bone phenotype, intact bone. The tooth is undergoing absorption, so we need to take it out. So the tooth is extracted, implants in a good position, more than 2 millimeters of a horizontal gap. It's grafted exactly the same way, sealed in, and the patient's own crown was then converted by Dr. Dickinson into the provisional. So this is the provisional crown on the left implant, and the 1-year outcome, good aesthetic results, some flattening of the ridge here, so you'll see some flattening still takes place, but it's still within, I think, aesthetic parameters. And the CBCT at 1 year showing the thick facial bone that's reconstructed. 9 years later, it's stable. No guided surgery back then. This was all, what does Professor Lucy say, brain-guided surgery to get the implant in the correct position. Okay, but we can still get a good result. And then one final thing, avoid facial malposition, especially when it comes to immediate implants. So we published this, 20 years ago. Even the slightest facial malposition increases your risk of recession. So you can see this case here, the soft tissues have receded. We have an angular discrepancy, but look at the bone. The bone is thick and intact. It's got nothing to do with the bone. It's to do with the angulation of the implant and the abutment. So today, no excuse to go into a facial malposition because we have digital planning, software planning that allows us to line things up. You can, any doubt, plan on the computer, create a digital guide, and when you go to surgery, make sure the implant is in the correct position. Because soft tissue recession, malposition is a significant risk factor. And the reason is because the implants are placed into the palatal apical region. And in an extraction socket, that is thick bone. And the implant wants to deviate to the facial side. And a 6-degree angular deviation on a 10 millimeter implant is a 1 millimeter change, and that's enough to get recession. And you can see from the studies we published, and then a systematic review, prospective study by Jan Kozin in 2012 from Belgium. The odds ratio is 17.2 for recession. It's huge. What it tells you, 17.2 means facial malposition, guaranteed recession. You want to guarantee something in life? It's recession with a facial malposition implant. So, irrespective of the timing of the implant placement in the aesthetic zone, with an immediate implant, what you want to do is to create an environment that has thick soft tissue, thick bone, intact papillae that are not damaged to the surgical procedure, and the CBCT showing you both thick bone and thick soft tissues. And if you go for an early implant placement approach, the biological objectives are exactly the same. The treatment is different, but where you want to end up is exactly the same. With late implant placement, so if you ignore the pictures and just look at the CBCT, tell me which one is immediate, tell me which one is early, tell me which one is late implant placement. You cannot tell, because they're exactly the same. And that's the whole primary objective of achieving good aesthetic outcomes in the upper anterior region. Okay, so with that, thank you very much for your attention.